Welcome to this short video on hip examination for revision. The objectives of this video are for you to know what to look for, what to ask the patient to move, what to move yourself, and what special tests there are. The examination sequence itself follows the usual orthopaedic mantra of look, feel and move. Begin with inspection, including gait, palpate the joint, move the joint through its full range, perform the special tests, examine the joint above and joint below, and order any investigations. Remember, there is rarely one way to perform an examination. However, there are lots of wrong ways to perform an examination. By sticking to traditional universally accepted techniques, you're more likely to get better marks than by doing something that one consultant finds works for them in their experience. Begin by introducing yourself with your full name and title and shake hands with the patient if it's something that you normally do. Confirm that you've got the correct patient by checking their name and date of birth, and explain that because of the problem with their hip, it's normal for you to do an examination of them, and that will involve them walking and moving their leg, and you looking, feeling and moving it as well. Then gain their verbal consent to proceed. Ask if there are any pain, and if they need any painkillers. Make sure they're adequately exposed to the examination to the iliac crest. Don't forget to wash your hands before you begin the examination. Ask the patient to stand and walk, observing their gait. A limp is an abnormal gait due to structural changes, tone, abnormality or weakness. To inspect the patient's hips, squat down to be level with the hips and inspect round through 360 degrees. In older patients or patients in pain, where there is room, it's more acceptable for you to move around the patient rather than for them to turn for you.
You can turn to face away from me. There's no gluteal wasting there. And you can turn around again. That's how you can finish up by facing me.
Trendelenburg's test is really a special test, but it's convenient to perform it at this point. Stand in front of the patient and hold their pelvis. Ask the patient to raise one leg. Normally, the iliac crest on the side of the foot raised should rise. If it falls, it may be due to gluteal weakness, inhibition from hip pain, or structural abnormality. Lower the head of the couch until the patient is fully supine. Tell the patient to let you know if it hurts and also observe their face for pain as you perform the examination sequence. Feel for tenderness over the greater trochanter, suggestive of trochanteric bursitis. Also feel for tenderness around the less trochanter and ischial tuberosity, which is common in sporting injuries. This is not shown in this video due to its intimate nature. Place your left hand under the spine to check to see if the patient is using their pelvis or spine during the movement phase. Check the range of flexion in both hips in turn.
Okay there? Okay, straight out. And I'm going to do the same with this one, okay? Bring it right up. Okay, so you've got a good range of movement there. Can you pop onto your front for me?
Ask the patient to turn onto their front and check extension.
Again, so do your
Make sure you place your hand on the pelvis to fix it.
straight up. Okay, let me know if it hurts. Is that okay?
Yeah.
Brilliant. And the same with this one. Okay, that's great. If you can pop onto your back again, Annie, for me, please. Okay, I won't do it now. I'm just going to bring your leg across.
Stabilise the pelvis by placing your left hand over the patient's left hip.
Okay. And bring it out. Same with this one. Bring it across.
The range of movement is usually 25 to 45 degrees from the midline.
Okay. Next thing I want to do is I'm just going to rotate.
Roll the leg on the couch and check the range of internal and external rotation.
I want to rotate it that way and that way. Okay. Same with this one. And external. Super. Okay. What I'd like to do now.
Then check with the knee and hip flexed to 90 degrees,
Turn your leg inwards.
moving the foot inwards to test for external rotation and outwards to test for internal rotation.
Okay, superb. And the same again. Just say if it hurts at any point. Alright? Okay, super. Okay, Okay, next thing I want to do is what's called a special test
Okay.
on your leg. Okay, so I'm going to put my hand on my back again. What I'd like you to
Place your hand face upwards under the patient's spine. Flex the patient's knees and hips as far as possible. You will feel that the lordic curve of the lumbar spine has been eliminated. Ask the patient then to straighten their test hip. Complete extension should be achieved with the lordic curve remaining eliminated. Incomplete extension indicates a fixed flexion deformity.
Excellent, that's fine. If you can straighten both legs out.
True shortening occurs when one leg is genuinely shorter than the other for various reasons. Apparent shortening usually occurs due to an adduction or flexion deformity. To differentiate between the two, with the patient supine, measure from the umbilicus to the medial malleolus to give the apparent length, then measure from the anterior superior iliac spine to the medial malleolus to give the true leg length.
Well, 82. That's fine. Ali, thank you very much. You can sit you back up. Okay.
Thank the patient and tell them that you completed the examination and invite them to dress. Wash your hands and present your findings back to the examiner in a logical format. Explain that you'd also examine the joint above, which is the spine, and the joint below, which is the knee, that you'd like to take a full history from your patient, and you may consider imaging and bloods depending on what you've found. Thank you for listening to this examination video. We hope you found it useful.